Коллеги, приглашаю вас занять ваши места, и мы готовы начать. Баграт Гигамович на связи, поэтому... Начинаем, да?
Я должен начать.
All right, shall I start?
Добрый день, коллеги. Мы рады приветствовать вас сегодня на долгожданном мероприятии.
We are glad to welcome you and master the complex. We would like to welcome our guests in Moscow, in Novosibirsk, those who are joining in online. And it's a pleasure for me to give the floor to academician Bagrat Alekan, a doctor of medicine, please. Good morning, dear colleagues. Good morning, dear guests, dear foreign guests and organizers who have joined in Moscow and in Novosibirsk. Today, we are opening Master the Complex 2021 Complex PCI School, and this topic is important for all of us, and we are going back to training courses to provide assistance to these patients who are quite severe in terms of their conditions. You know that the number of PCIs is increasing every year in Russia. In 2019 was the record year when we had 255,000 PCIs in Russia, and on average, the indicator was about 1,780 PCIs per 1 million people. Soon there will be new data, and I guess a little bit later there will be data on 2020 in terms of the number of PCIs, but we can see that there was a certain drop in the number of PCIs, but as for absolute figures, we had a 10% drop as compared to 2019. These are preliminary figures, but soon you will see the final figures showing that there was a 10% drop in the numbers of PCI in 2020 as compared to 2019. These are the Russian data, but in some countries the drop was even 20% and more. But well, we will move on, and today we'll be talking about coronary arteries occlusions and bifurcations, issues related to drug-eluting balloons, rotablation. These are important technologies allowing interventionists to operate, usually where cardiac surgeons operate. We know that the situation has changed, and now these new technologies allow us to come up with new guidelines to treat these heavy patients. What else can I say here? In fact, today you will see different data, what percentage of patients will have PCIs when there are total occlusions like CTO, when there are bifurcations. But what is important is to use different imaging methods Here we have a serious problem in Russia. Usually we have 1 or 2% when IVUS is used. The same is true of OCT. Well, we started using FFR a little bit more, but still, well, the percentage is very negligible, very small. We're very concerned about it. And I should say that last year, the Russian Scientific Society of Endovascular Surgeons, together with the Commission of the Ministry of Health, we started on a new path. The goal was to convince the Ministry of Health to provide guarantees for using IVUS, for using OCT, for using FFR, so that all these interventions could be reimbursed. And about 10 days ago, a decision was taken, and I informed all Russian centers. And today, by the way, you can see it on the portal of the Ministry of Health. We were quite successful in a way that the sums, the financing allocated for reimbursing imaging modalities and FFR is about 550,000 rubles. Well, but I think depending on the region, it will be about 400,000 rubles for a particular intervention. And I hope that next year will have a very good situation in terms of reimbursement of these procedures. Well, there is another thing. Well, 740,000 rubles per procedure has been allocated for this. And I think we should pay more attention to such training courses as we're having today. I'd like to say that the advisory board of the society has developed a plan, and soon we'll have a meeting. I can see Vladimir Gannikov, who is the general secretary of the Russian Society. He is here at this meeting, and soon, within the next 10 days, we'll approve the plan of action for next year. We are planning to have 5 major events, and the first event that we are planning to have in January, it will be an all-Russian conference, a 2-day conference on imaging modalities, and in particular, fractional flow reserve, FFR. Well, we're doing this because we now can start using FFR in 2021, but many of our colleagues, and there are about 2,000 of us, are not familiar with this modality. So we will have an all-Russian conference on FFR in January, and there will be a second conference on interventions on peripheral arteries and aortas. Then we're going to have the 11th conference at TCT Russia. Well, this year there will be TCT Russia in Moscow, then structural diseases, and in December next year we will just have a conference on acute brain circulation problems. So that's our plan. Within the next 2 weeks, you will get the full information in each federal region. And we have 8 federal regions in Russia to have at least 2 master classes, not for the entire country, but for a particular federal region. And we'll be talking about chronic occlusions while using IVUS, while using OCT and FFR. And obviously, this means that we can achieve better results. We'll involve Russian experts who are also participating in this conference, and we'll invite also foreign guests. So I think that this teamwork will help us drastically change the situation. with the use of different imaging modalities, and we'll be using these imaging modalities en masse. So at least the indicator should be 15–20% as far as FFR, as far as IVUS and OCT are concerned. That is why master classes will be of great importance, and starting from next year, we'll have colossal opportunities to organize such master classes all over Russia. And here we need to pool our efforts, and I hope that the companies will be working with us. In conclusion, I would like to welcome all of you, and I would like to wish you every success at this master class. Thank you for your attention. Thank you, Professor Alekian. Now I'd like to give the floor to the General Manager of Boston Scientific in the Eurasian Union, Guillaume Ochelter, please.
Спасибо. Маша. Да, уважаемые профессоры, уважаемые докторы, все, которые с нами сегодня на онлайн или на хаб, я очень рад приветствую вас на нашей встрече Master the Complex. Я тоже очень рад, что Маша со мной, чтобы я могу говорить по-английски. Just want to say a few words on Boston Scientific, to tell you that you know it, we have the broadest portfolio in complex PCI, and this portfolio is being constantly updated and improved by our team. We believe, and this is the purpose of these events, we believe that education is critical for you as a doctor, for the therapy itself, to get the fair market share it deserves and to increase the adoption rate on the market, and for the patients as well, in order to receive the best treatment available.
Я хочу сказать несколько слов про Boston Scientific. Я думаю, что вы все знаете, что Бостон имеет самое широкое портфолио в области сложных коронарных интервенций, и оно постоянно пополняется, разрабатываются новые решения. Мы в Boston Scientific считаем, что обучение – это ключ к тому, чтобы успешно реализовывать терапию на рынках. Это ключ к тому, чтобы вы, как специалисты, уверенно себя чувствовали, работая с продукцией. И, конечно, это наиболее важный момент для наших пациентов, чтобы они могли получить более качественное лечение.
So today we introduced the Master the Complex training, which is a training well known and established around the globe for Boston Scientific community. And I'm very happy to have this happening for the first time in Russia, not only in Moscow but also online. And I'm happy to see so many faces in the room here. I would like also to thank Professor Alekian for his support, to thank all the moderators, all the operators, all those who make this event possible in this pandemic time. I hope you will enjoy the session. I'm very much looking forward to get your feedback on this training to make it even better, even more supportive for you, and looking forward to seeing you after the meeting today.
И сегодня мы открываем мероприятие Master the Complex. Master the Complex – это бренд обучающих мероприятий Boston Scientific, который широко известен в Америке, Европе и других странах. И сегодня впервые это мероприятие состоится в России. Я бы хотела поблагодарить профессора Аликяна, наших модераторов, спикеров и, конечно, всех тех, кто собрался с нами в Москве, в Новосибирске, кто смотрит нас онлайн, всех тех, кто смог сделать с нами это мероприятие. Я желаю вам удачного дня, и мы открыты и ждем вашей обратной связи для того, чтобы мы могли сделать это мероприятие еще качественнее, еще эффективнее и полезнее для вас. Всем хорошего дня.
Спасибо.
Коллеги, и передаю слово Алексею
Colleagues, and I'd like to give the floor to Alexei Kononov, unit in the Eurasian Union. Good morning, dear colleagues. I'd like to welcome you as well. And I would like to express my gratitude to anyone who has joined us here in Moscow, online, offline, in Novosibirsk. I'd like also to thank Professor Alekian and to all our leading specialists who are managing this process. For us, as it has already been said, this is one of the key events due to the peculiarities of the portfolio of our products. We pay a lot of attention to complex coronary interventions, but for Boston Scientific Russia, this is a milestone event because we just organize such events as an independent organization in the field of coronary surgery for the first time here. Our team is rather young, well, in terms of experience, in terms of our presence in this segment of medical devices. The team has done everything possible and even impossible to make this event happen. So do not be very strict judges, but on the other hand, we'll be very glad to get feedback from you as soon as this event is over. I would like to wish you every success in your endeavors today. Thank you. Well, good morning, dear colleagues. I think we can start our scientific program. The first presenter, well, the real and hidden problems of the full heart vascularization. Dear members of the Presidium, esteemed colleagues, I'd like to make a brief presentation. Please share the screen with us. We would like to see the slides. Well, obvious and hidden problems of full cardiac revascularization. In fact, well, despite all our achievements in interventional cardiology, the problem of full revascularization is still open. And I should say that, again, despite all the achievements, angioplasty does not demonstrate obvious advantages, even if we compare it with optimal medical therapy. This meta-analysis, which was shown at the last TCT, patients with stable angina, well, when we did the analysis of all studies, including ischemia, angioplasty, and CABG, did not show advantages in terms of death from all causes or myocardial infarction. However, there are some trends when these methods, such as angioplasty and CABG, have advantages as compared to optimal medical therapy. This slide shows that invasive interventions reduced the number of adverse events as well as rehospitalizations as a result of unstable angina. Well, the problems of coronary revascularization are shown here. First and foremost, we'll be talking about incomplete heart revascularization and the advantages of complete revascularization. The sub-study ischemia showed a lesser number of MI after invasive interventions. We can see full revascularization is achieved here when we did the anatomical assessment. And you can see some of the parameters here and the endpoints. As we know, there are two types of assessment, the anatomical and functional. And here, I should say that the American Heart Association published a document this year on how to properly assess the completeness of heart revascularization. Here, one of the major tables shown here and that's a rather complex document. The main thing we should know is that we divide the main trunk and all other main arteries. We can also have a visual assessment of stenosis. Usually when there is a stenosis of more than 50% in the main trunk and more than 60% in the main arteries. In this case, the stenosis is considered to be significant according to angiography. In quantitative angiography, it's more than 50% both in the main trunk and in the collaterals, according to this table. Well, but the main method of assessment is still functional testing, first of all, such as fractional flow reserve, FFR, and also the pressure coefficient without hyperemia, such as IFR, and other assessment methods. But first and foremost, we must, of course, if these methods are not available in a particular country or area, we should choose non-invasive methods with imaging modalities such as myocardium scintigraphy or stress testing with EKG. Here you can see our data. 155 patients were included in the study with full and incomplete revascularization. As you can see on this slide, the patients are very similar. However, as for full revascularization, the follow-up period was more than 1 year, 470 days, to be more precise. Patients with incomplete revascularization, we had to do the intervention much earlier after the primary intervention. Well, the negative results of full revascularization, according to our study, was the coronary thrombus and the progression of native coronary atherosclerosis. Maybe this is due to the number of stent implanted. PCI, in case of repeat intervention, was more often done on patients with incomplete revascularization. You can also see how complete revascularization gives much better results as compared to incomplete revascularization in terms of lack of any events within a 5-year period. So revascularization is a positive factor leading to a lack of adverse events. And of course, I should say that all our achievements were not possible unless there were no new stents and equipment like Megatron was presented by Boston Scientific, where the cell can be inflated up to 5 millimeters, which is very critical for main trunk lesions. Another device is shown here. That's a stent positioning assistance system. It has already been used by American and European colleagues. We have already had an agreement with Boston Scientific to start studies on stent positioning using this device. I should also say that Boston Scientific also presented new guidewires to measure FFR, the new rotablator, well, also the new catheter for IVs, and you can see the new guidelines. These are new Russian guidelines. They stipulate the parameters for the use of IVs to assess the functional importance of stenosis. There are also preliminary figures, something which is more than 7.5. In this case, you do not revascularize. When it's less 6.5, in this case, you should revascularize. According to these guidelines, we recommend you do complete revascularization, but at least 72 hours later on patients with STEMI. Russian guidelines were developed on the basis of European recommendations, and they stipulate that you should revascularize as soon as possible, but all patients, before they're discharged, we must assess the risk of follow-up events, and first and foremost, to assess the completeness of revascularization by using different methods, well, residual syntax score or doing specific tests, but we must remember that our goal is complete revascularization, first and foremost, functional revascularization. Other problems such as the progression of atherosclerotic processes and instant stenosis are still open, and we must also cope with these problems. Well, first and foremost, I'd like also to say that our new methods will allow us to achieve better success. All new devices that we're going to present today are aimed to prevent incomplete revascularization and to prevent adverse events for patients in the future. Thank you. Thank you very much. We're slightly overrunning the time, but let's have a discussion today. It's an important event. We're talking about the technologies which seem to be totally inaccessible in Russia, and there will be no reimbursement, such as imaging modalities and FFR. My question is as follows: if patients with multivessel disease, will they be able to have FFR to assess the importance of stenosis, or send the patient for stress test for multi-stage surgery, well, to identify the maximum ischemia area? What would you use? What would you choose in this case? Well, the first line of choice is FFR. The second line, stress test and the imaging, but we must remember that the recommendations stipulate that FFR cannot be used to assess other vessels when there is a STEMI patient. So when the patient is stable, well, in this case, we can do additional FFR or IFR, but if the patient has a cardiogenic shock, we revascularize only the infarct-related artery, and the procedure stops here. But right now, there are also a lot of other methods without hyperemia. And I think that in the near future, we'll be able to achieve the situation that all patients will have FFR during the primary intervention.
And this is how we will get to know the completeness of revascularization. I think the technologies will become cheaper with time. It will be more affordable. And as far as I know, we have discussed with Dmitry Vladimirovich that the problem of tariffs of these researches is under discussion now. So let's hope that if this is compensated, then it will not make the procedure significantly more expensive. Thank you very much. According to the information I have from January, it will be compensated at least in some patients. I think it's a big dilemma now. And as we talk to the cardiologists at the conferences, I often hear, why would we spend so much money on FFR? We have stress tests. Let's do it on the ultrasonic machines, FRT. But I think with multi-vessel disease, we can only give a response efficiently when we look at FFR, and we have lots of patients like that. And I think we need to try and achieve that we do have these methods of visualization. Hopefully, from the next year, we will have the quota. At least there is a rumor about it. Thank you very much for your great question. I think that this question, the answer to this question will define in the nearest future the future of vascular visualization and imaging. Let's not forget, we can see ischemia with epicardial arterial transformations, while we have distal problems that we cannot see, visualize. This is something we need to take into account. So this is a very tricky balance we need to respect, and cardiologists should have a certain amount of confidence in us. And you are absolutely right that everything new is very hard to perceive. Thank you very much. Colleagues, am I allowed to make a comment? We have two moderators. We have the OR connected. We have Mr. Dr. Ganyukov and Dr. Polyakov, and Sergey Alexandrovich is also with us. Am I allowed to make a short comment? I can't see everybody immediately. I only see myself and the first two images. Good morning, dear colleagues. Sergey Alexandrovich wanted to say something. Can you hear Siberia? Yes, we can hear Siberia. Hello. We from Siberia are asking Sergey Abugov to turn on his mic and say something. You probably don't hear him in Moscow, but he was asking for 2 minutes for a comment. Yes, with great pleasure. Sergey Abugov. Yes, Vladimir Ivanovich is a friend of mine. Thank you very much for being so supportive from Siberia. Well, we know Siberia is the power of Russia. Thank you very much, Vladimir. I want to be concise. It was a brilliant presentation. Thank you very much. All was great. The only thing is, as usual, when we look at ischemia study, it's very trendy to say that it didn't show any advantages of coronary angioplasty. I would say no, it did show the advantages because there was a reduction of the number of spontaneous infarctions. We have a big evidence base saying, both meta-analysis and separate studies, saying that recanalization of chronic occlusions is extending the life of the patient significantly. And this is great. And frankly speaking, we have more and more evidence now that stenosis over 70% in many cases. Well, I'm saying this with cautiousness, but it is possible to do the stenting there if there is no possibility of IVUS and functional assessment. Second thing I want to say regarding the time it takes to do the complete revascularization during acute MI. There is a disputable question when exactly this should be done because different studies mention different timelines. According to the evidence, there is no need to do it all within 72 hours. In complete study, the mean time before revascularization was 23 days with a maximum time up to 45 days. That is to say, if for logistical, financial, or whatever reasons, we are not fitting in this window, we have around 1 month to do the complete revascularization. Thank you again. I want to thank the organizers for this amazing meeting, and thank you to the brilliant speaker. He was really amazing. Thank you very much. Thank you so much. I think we will follow the agenda, and now we have to connect to the OR. We have two ORs. Yes, one is the Central Clinical Hospital of Russian Railroads. Can you hear us? Can you see us, colleagues? Russian Railroads Medicine, yes. Can you see us? Can you hear us, OR? Yes, we can see you, we can hear you. Oh, we can see you. Dear colleagues, please introduce the patient and the case and your progress at the moment. Good afternoon, dear colleagues. On behalf of our department, I would like to express the gratitude to the organizers of the course for the opportunity to demonstrate our clinical case. Today, I'm assisted by Dr. Olga Safonova, nurse, OR nurse Anastasia, and Daniel, our resident. Olga, please briefly introduce the patient. No microphone? Male patient, 51 years old. The main diagnosis is painless myocardium ischemia. The stenotic atherosclerosis of coronary arteries. He didn't have any pains, but every now and then he had the elevation of arterial pressure up to 170 millimeters mercury bar. He was admitted to the coronography. We did it. We could see the stenosis in the ostium of the anterior descending artery. We measured FFR and we saw that the stenosis was relevant, and we decided to do the angioplasty and do the stenting of the coronary artery. Thank you. You can hear us, colleagues? Yes, we can see, we can hear you. Well, for the first sight, it may seem that this is quite a simple failure. However, if we treat it in the paradigm of the recent 15th consensus of the European Bifurcation Club, then we may have a lot of questions. The first question is how to position the stent. We are allowed at the moment to do the stenting of the ostium failures from under the ostium, but we need to have adequate anatomy for this. In this case, in our opinion, the anatomy is not so suitable because there is no direct angle between the circumflex and anterior descending. And also there's a certain arching wave of the anatomy. So when we implant the stent under the ostium, it is possible that the proximal angle, the angle of the proximal part of the stent will be prolapsing in the terminal part of the left coronary artery, which is not an optimal position. Moreover, we managed to do optical coherent tomography, and as expected, we could see that the atherosclerotic platelet is going to the terminal part of left main, and we don't want to cut it. The most optimal option of stenting, in our opinion, is the stenting, provisionary stenting from the anterior descending artery to the left main. Would you agree with us? Thank you very much for your strategy, dear moderator. If you want to add something regarding the strategy, well, before the PCI, there are less questions than after it. I'm sorry to interrupt you. If you want, we can show you the data of optic coherent tomography. Yes, that would be great. While they are demonstrating, if I may make a short comment, this is a very interesting clinical case. Patient with no symptoms, arterial hypertension, and he was done coronography, and then they saw the narrowing, they defined the flow physiology, they saw that it's a hemodynamically relevant stenosis. Based on this, do you think that all the people with hypertension are indicated as the stenting? How did you catch this person? How did you identify him? If I may answer, you know, there is I would say that we have lots of patients that are admitted to the hospital for occupational reasons. If they are not examined medically every now and then, they may be deprived from their work. So every now and then they come for checkups, and this is how we detect it. Maybe this patient doesn't move much. Yes, but we normally have railroad workers, and they are working hard physically, and I think he had also angina. Okay, would you comment the imaging? Do you see the CT? Look, can you see it? Yes, we can see it on a small screen. So this is quite a big lesion. MLA is 2022. On the side of stenotic part, on the stenotic part, MLA is around 3. The proximal intact part of the anterior descending artery is around 12. The maximum diameter is 4.45. We decided to use synergy stent, considering that it helps to expand the mesh proximally in the lesion. That is to say, we can position it really well without any loss of radial robustness during the final kissing. We will choose 4.5 diameter, I guess. May I ask a question? What is the length of the stent you are going to apply, and how are you going to define the proximal and distal edges of the stent? Looking at the angio, I can say that this is quite a lengthy failure, and it goes significantly into the proximal part of the anterior descending artery. And where will be positioned the edge in the lesion? Thank you for your question. We will base our strategy on the data of optic tomography. We could see the stenotic part in the median part of left main and in anterior descending artery. So we have defined for ourselves the length of the stent being 20 millimeters. Does everybody agree? I think in this situation, the length of the stent should be slightly longer. It should go deeper in the anterior descending artery. Looking at the size of the failure, you need to find a more or less healthy site, or to look at the proliferation of the platelet to traumatize it as less as possible during the implantation. Well, the length of the stenotic part is around 10 millimeters, and we took 5 millimeters on both sides, and we want to do the stent 4.5 by 20 millimeters. Well, yes, I agree. On CT, the failure looks quite short. We can see that there's a quite short segment, and you have extra space of the stent, extra length. Should be enough. Okay, please inflate the stent. Open the stent. From Siberia, the moderators agree with the strategy of choice based on OCT. And since you have made a calculation, it is logically explained by the operator. We agree with 20 millimeters. May I give you a microphone? Yes, if you want to make a comment from the audience, please. Thank you. Anatoly Larionov from Astrakhan. I want to comment regarding the stenosis. We usually choose the provisioning stenting strategy in the following way. We choose the length of the stent based on the balloon available for proximal optimization. If the minimum balloon is 8 millimeters, then we select the stent respectively, that it should be proponent by 8 to 10 millimeters to the left main. And here, if we have 5 millimeters of proponent part from each side, it turns out that the balloon angioplasty in the left main will go to the intact part of the left main. It will be covered by the balloon. I know that it will be stretched and it will not traumatize it so much, but I think this site, we should have a stable part of the site in the left main so that we could easily do the proximal optimization and meshing. Let me answer. You know, our laboratory it is prohibited to do the balloon angioplasty and post dilatation beyond the margin of stent. So any procedure we do is done accordingly. It is not acceptable to do an excessive traumatization and do post dilatation on the part of the lesion that is not protected by the stent. I think this is what the operator will do now. And I have a question to the operator. Do you think we should do pre-dilation in this situation? How important is that to have a well-positioned stent without sliding in the artery? Or do you think to stent immediately? Are you going to stent immediately? Aren't we afraid that we might have? Is this a question about? Is this a question to you? Pre-dilation. This is a question about predilation. Do you think in this case predilation is necessary based on the fact that it can help you to do a more precisional stenting of left main? Thank you for your question. Well, the optical coherent tomography shows we have the minimum diameter to do the passage without any problems. If you're talking about optimizing the platelet before stenting, in my opinion, there are no strong prerequisites to do this. Yeah, there is no strong calcification and there's no risk of poor inflated stent, and I don't think there is a risk. When we have FFR and visualization, we can be more confident, we can select the sizes of stent, the length. Yes, we're waiting for the result now. We will not distract you from your work. Maybe the audience wants to make comments, but don't get distracted, please. Well, the audience is sitting and being jealous of you. You know, they envy you. How many people in the audience would take for such a failure visualization and would do the stenting immediately? I hope you can hear me, colleagues. I think, first of all, if we introduce yourself, please, before. Please introduce yourself. Machenko Alexei Nikolaevich. And please, every time you speak from the audience, introduce yourself because you are not shown on the video. Well, the projection is towards right to the feet, I would say. If we're looking at the right positioning of the stent at the ostium of the lesion, I think the projection should be a bit leftwards and towards the head, because based on this imaging, if I was careful enough to notice, it wasn't. Well, I think initially the surgeon was not planning to do the stenting under the ostium, but he was planning to do it in the lesion. But I absolutely agree with you, and stenting under the ostium should be done in one and the only correct projection towards the head and leftwards. Of course, if we were doing the stenting to the ostium of left main, then we would take into account the projection. You didn't reach the ostium. No, we didn't want to do the coating of the entire. Okay, do the OCT and we will see it.
Уважаемые коллеги, если можно еще пока оператор работает, у меня такой вопрос. А вот сейчас
I
вы
have
при
a question,
настенкировании
colleagues, while the
рadiографически
operator is
условно
working.
приемлемый
Now the
результат.
stenting is
Кто бы выполнил
being
дальше
done.
киссинг,
And
дилатацию, кто бы
conventionally speaking,
выбрал,
it's a angiographically
скажем так,
acceptable result. Who would do a kissing dilation? Who would choose subsequent kissing balloon technique? And who would leave this angio as it is without any dilation of the ostium of circumflex artery? Is there anyone who wouldn't do the dilation? No, of the circumflex ostium? No? Everybody would do that? Kissing balloon technique? What about kissing?
Да. Будьте добры, прокомментируйте.
Сомов Павел, Москва.
Pavel Somov from Moscow. This is a young patient, isolated stenosis of the anterior descending artery. I think we need to do kissing and then repeat POD because anything can happen in the long-term follow-up. You mean physiological bifurcation, Corina, and then, okay. Sergei Vlasenko, Clinical Hospital number 40, Sestradetsk. Look at where the edge of the stent is, the proximal part. And now imagine we go there via mesh. This is the edge. Which diameter of a balloon should be used here? If we go there via the mesh, you mean the lateral? This is an important thing. There should be a technique here, when the guide shouldn't go beyond the edge. No, I mean a different thing. Look, the pre-last mesh will be deformed because we will pull it with the edge of the stent. Well, we will have a CT visualization and it will show if it's deformed or not. The colleague said he wouldn't do this, but here is a question of a situation when the stent is positioned like this to pull the last mesh. It's not a nice thing. I understand that this is classics, but we should treat it individually. Every year we see the small studies published saying that if POD was done nicely, then we can stop hereby, and the follow-up, long-term follow-up result would be as good as in a case when we would do the global bifurcation. But if we do it under visual control and if we use a big balloon, it turns out that in POD the meshes are spread aside so well. I agree with you, simple, swift, and safe. This is the main principle of PCI surgery. And if we do something good, maybe it's worth to stop hereby. Okay, based on this, I would ask you, since I'm the moderator, can you just completed POT technique. Can you do the OCT and we will visualize it, and maybe at this point we will finish the intervention. Zaur Hasanovich, here it is. This is what we wanted to do. We are, yes, inserting the CT sensor. And please tell me, what was the balloon that you used for POT? NC Emerge 5x6, the smallest. Okay, thumbs up, like for you. Colleagues, they say that the second OR is waiting for the connection. If we can disconnect and go to OR number 2. Okay, that's a good idea. Okay, we are leaving you temporarily and we're going to the Myasnikov Institute OR. Please be ready. We will reconnect with you again. Can you hear us, colleagues? Yes, we can see you. We can hear you. Good morning. We've prepared for you multi-vessel disease case, a lot of bifurcations, and we have lots of questions to you. We did something before we were connected to you. We will present the clinical case, show you the angio and the IVUS result.
Вашему вниманию представляется пациент
Uh,
63 лет.
Male patient 62 years old with angina of third functional class, history of disease, long duration of elevated arterial pressure up to 220 millimeters mercury bar, hypertensive therapy. In 2007, patient had MI of low localization, FFR, ejection fraction 52%, angina since 2013, first, second functional class, normal quality of life, rapid deterioration and progression to the third functional class in August 2021. In August 2021, the patient was hospitalized to the Mordovia Central Clinical Hospital because of the angina progression, where he was done angio. On the angio, in the left main, left coronary artery, we can see the stenosis of the terminal part with the propagation to the ostium, and you can see bifurcation stenosis Medina 1-1, and we can also see stenosis in the anterior descending artery. Both diagonal arteries are stenotic, and stenotic proximal third of the circumflex artery, large lesion. Angio of the left main, where in 2007 he had a large MI. There are lots of stenosis throughout the length with maximum narrowing up to 80%. To make a decision on the strategy of revascularization, we had a concilium. We evaluated the syntax score, and it was 33. As we evaluated syntax 2, we found out that given the comparable risks of intervention and long-term follow-up, PCI treatment is of more benefit for the patient, considering that the patient was not ready for open heart surgery. And since we have a lot of experience with PCI, we made a joint decision on PCI revascularization of left coronary artery. Regarding the right main, we thought it would be the second stage after we assess the myocardium function and considering the ischemia, considering that 14 years ago he had a large MI in this basin. Thank you so much, Maria Leonidovna. If you can see the screen, colleagues, I will show you the angio that we did right now.
Спасибо большое. А можно кардиологу задать вопрос пока?
Thank you. Can I ask a question to the cardiologist? First of all, thank you very much for a well-presented academic presentation. This was exemplary, wonderful presentation. Thank you. I have a question about ECG. We have a compromised ejection fraction. What about the lower wall? Do we need to understand additionally the aneurysma, hyperkinesis, or whatever is happening to the myocardium because of the ejection fraction? There is no aneurysm, ejection fraction about 52. There are sites of akinesis of lower localization and hypoakinesis in the basal segments. But considering that the posterior descending arteries occluded, we believe that additional research is required, especially if we don't see angina after revascularization of left main. What are the additional methods you are going to use? CINITY, MRI? Well, initially, we would probably do stress ECG, and if we were to detect ischemia there, we would stop and do revascularization. If stress ECG would be informative, then we would do MRI, I guess. Thank you very much, Evgeny Vladimirovich. Sorry that I interrupted you. We're waiting for you.
Well, we had a dilemma what to start with because there are a lot of branches affected of large diameter and they need to be revascularized, and that should be complete revascularization. The trunk, the stem is the most important lesion, and it didn't allow us to pass the ultrasound sensor, we used a small balloon, 2.5, so that we could use the sensor along the branches. Well, I suggest we assess angiograms at a projection toward the head. Well, and you can see basically LAD, which is a kind of bizarre, and you can see the diagonal artery with the proximal lesions and orifice lesions. There is another collateral, well, 24 millimeters, and the first one is the intact one. Well, you can see the lesion here of the proximal segment of the diagonal artery. Well, but you can see also the spider projection. You can see the trunk, the diagonal, first, second, third. Well, plus we can see the proximal lesion of the circumflex artery. We did a pullback, and you can see it here. Well, that's the circumflex. Second, from the blunt margin artery, and third from the diagonal branch, third diagonal branch with the orifice lesion up to the orifice of the trunk. And now we will see the IVIS results and we'll make some comments. Hello. Well, I will show you the first pullback. The first pullback was done from the circumflex artery in the middle circumflex, to be more precise. Well, there is no atherosclerosis here. We can see the vessel walls are quite clear. We can see the maximum diameter of the circumflex. It's 3.2 millimeters. In the middle segment, there is the atherosclerotic plug. Well, the lumen area is 4.5 millimeters square. Well, 56% is the volume of the plug. When we analyzed the orifice of the circumflex, well, the blunt margin artery, well, you can see the orifice of the circumflex is free from atherosclerotic plug. The maximum narrowing in the circumflex is in the orifice before bifurcation with LAD. 53 square millimeters is the lumen area, and after bifurcation in the terminal part of the trunk, the plug occupies 71%, 4.72 square millimeters. When we did the pullback from the blunt margin artery, you can see the blunt margin artery has about 4 millimeters in diameter. The maximum narrowing before bifurcation is about 3.74 square millimeters, which in terms of the area is quite a significant lesion. So also here you can see a plug occupying 73% of the lumen area is 2.94 square millimeters. We did a pullback from the diagonal artery, and you can see the diameter of the diagonal artery. Well, it's the distal to 2.66 millimeters, 26 millimeters, and the maximum narrowing in the orifice